Thank you for joining us today. I'm Paul Heidenreich, chair of the CTAF panel. We'll be discussing prophylaxis for hereditary angioedema with lanadelumab and C1 inhibitors, effectiveness and value. Before we begin, we want to ensure that all speakers and all members have financial relationships disclosed with health industry. Every member of the CTAF panel has met the conflict of interest policy, although as we go around the room and have each of you introduce yourselves, please let us know if there's been any update or change to that. And then following the CTAF panel, we'll go to our patient representative and our clinical expert who's on the line. So I'll begin. I'm Paul Heidenreich. I'm a cardiologist and professor of medicine at Stanford University, Palo Alto, VA, and no changes to my policy.
Annetta Langer-Gould. I'm a neurologist at Kaiser Permanente, Southern California. No changes.
Patricia Powers, Center for Healthcare Decisions with UC Davis. No changes.
Rita Redberg, cardiologist at UC San Francisco, and no changes.
Robert Rensler, retired medical oncologist, Beaver Medical Group. No changes.
Kimberly Gregory, professor at UCLA and OBGYN at Cedars-Sinai Medical Center. No changes.
Bill Remack, chairman of the California Hepatitis C Task Force. No changes.
I'm Joy Melnick-Coe, professor of family and community medicine at the University of California, Davis, and director of the Center for Healthcare Policy and Research there, and I have no changes.
I'm Jeffrey Hotch. I'm a professor of health economics at the University of California, Davis, and associate director of the Center for Healthcare Policy and Research, and no changes.
Rena Fox, professor of medicine, UCSF, general internal medicine, no changes.
Felicia Cohn, bioethics director for Kaiser Permanente, Orange County, no changes.
Bob Collier, patient advocate with Patient Advocates in Research, and I have no conflicts whatsoever.
Alex Smith, I'm a palliative care physician at UCSF in the Division of Geriatrics, and I have no changes.
Elizabeth Murphy, I'm also a UCSF professor of medicine and endocrinologist, and no changes.
Jeff Klingman, neurologist, the Permanente Medical Group, no changes.
Thank you. Ms. Smith?
I'm Stephanie Smith. I'm a patient advocate. No changes.
Thank you. And I believe on the line we have Dr. Marco Ciccardi. Could you please introduce yourself and let us know if there's any changes to any conflict of interest?
I'm sorry, but the audio is not very good, but I think you asked me to introduce myself.
Yes.
Yes, okay. I'm a physician and I work in Milan, at the University of Milan, in a teaching hospital. And I'm in internal medicine, and I have been working on hereditary angioedema starting from 1973. And since then, I've been following patients with hereditary angioedema. Today, we have a group of patients of about 600. And I've been working on the pathophysiology and the genetic of angioedema, doing works on RNA regulation of C1 inhibitor synthesis and on the role of bradykinin in mediating angioedema. Now we are engaged in trying to get working a registry of patients with angioedema, a registry which collects data from physicians at angioedema centers and from the patients. The registry is already started, and I think that now it contains about 700 patients, but we hope to see it growing quickly. And there are 4 countries already participating in the registry, and we hope to have more of this registry. In terms of my involvement with the clinical trials, I've been involved with almost all of them. And therefore, I've been dealing with all the companies that are involved in HA. That's going to be my disclosure.
Yes, thank you. And we have the list of your conflict of interest, so I'll assume that we're saying there's no change to those relationships. And so I would like to let everyone know who will be speaking, roundtable participants or other individuals making public comments, to please announce any financial relationship with industry or other potential influences on judgment before you speak. And we'll also try to prevent this information publicly on the slides. So at this point, I'd like to introduce Dr. Stephen Pearson, President of ICER, to give us an introduction to the ICER and CTAF program.
Yes, good. There we go. Good morning, everybody. I can tell that Dr. Hagarde, are you able to hear me clearly? Maybe not. I'm just hopeful that our webcast audience can hear us. It sounds like we may be having some audio issues. So, and I would just encourage the CTAF members to continue to try to make sure you can pull the microphone close when you speak. So good morning and welcome to the CTAF and to the audience both here and via the webcast. I'm Steve Pearson. I'm the president of ICER. And you've heard from the members of CTAF, an independent appraisal committee. I want to tell you briefly about ICER, which serves as the secretariat, if you will, for this process. Our sources of funding, which is kept as an updated pie chart on our website, as it shows here, approximately 78% of our overall revenue comes from nonprofit foundations, and that supports the work that we do on these reports. And the chief funders within that group are the Laura and John Arnold Foundation, the California Healthcare Foundation, and the Blue Shield of California Foundation. We do take approximately 19–20% of overall revenue for a separate policy summit process that we run. Those funds come in from both manufacturers and from payers and PBMs to bring them together once a year and to have ongoing webinars around specific evidence policy issues where we feel that collaborative efforts between manufacturers and the payer community can be beneficial. So why are we here today? Well, as is commonly the case, when we have a new treatment that offers a new treatment paradigm, it really does offer innovation that can be really important to patients and their families. And I have a quote that comes from a newspaper article, and it describes the struggles of at least one patient who has hereditary angioedema. The swelling attacks come on without warning. Lakeisha Olive McCoy's lower lip puffs up, then her cheeks and jaw twist and pull, distorting her face into an involuntary grimace. Sometimes her tongue will fill up the back of her throat and choke off her breathing. I'm very expensive, Olive McCoy said. By the end of the year, our pharmaceutical bill, meds alone, can be $1 million, can be $2 million without even trying. So this article obviously nods to the cost issues, but I don't want to overwhelm the importance of the clinical innovation that can be important for patients and their families. So we're here to talk about a new paradigm of care, the prophylactic treatment of patients with hereditary angioedema. And as always happens, when we have a new mechanism of action or a new paradigm of care, it does raise questions about the appropriate use of these treatments, which patients can benefit the most, and it raises questions about the relative cost and cost effectiveness. For patients themselves, new treatments often bring new questions about how they will work with insurers around prior authorization criteria, whether they may face requirements to switch drugs or to try certain drugs first as part of coverage. And almost all the time, for treatments of this order, they will have high out-of-pocket costs one way or the other. So we feel that the CTAF provides an important opportunity for the public to engage in a more transparent discussion of the evidence and how we can learn about best ways to translate that evidence into education for patients, into clinical efforts, and into coverage and pricing policies that really can advance the ultimate cause of sustainable access to high-value care for all patients. The report today that was part of the background for the CTAF was developed with an initial intensive scoping phase with guidance from patients, clinical experts, manufacturers, and other stakeholders. The evidence analysis was performed by a team of UCSF and ICER staff, headed by Dr. Grace Lynn, who's here today and will present those results. A cost-effectiveness model was developed by colleagues at the University of Washington, and Dr. Solomon Lubinga is here to present those efforts. The reports go through several cycles of public comment and revision, and they also undergo expert report reviewers, and one of them, Dr. Marcus Hagarde, is with us today, as is the other expert, Stephanie Smith. So we're very appreciative of their efforts to review earlier versions of the report and for their participation today. Now, how in that report is the evidence organized to support the discussion? Well, again, if the goal can be commonly held as sustainable access to high-value care for all patients, we think, and the report reflects, that there are two important dimensions to think about. One is the long-term value for money. That really is the long-term, even over the lifetime of patients, if we're trying to estimate it out that far. What are the long-term clinical and economic outcomes? And how do we put those together to think about value? And there is shorter-term affordability concerns for the health system. Now, the report is clear that long-term value for money itself is a composite concept, and so we're going to talk about the evidence on comparative clinical effectiveness. We're going to talk about the incremental cost effectiveness, again, long-term. And we're also going to talk about and have votes on what we call other potential benefits or disadvantages of treatment options and their contextual considerations, so that that can be part of the thinking of policymakers and others. For short-term affordability, the report tries to capture estimates of the potential budget impact, and we'll talk a little bit about the relative size of patient populations that clinical experts believe will benefit from treatment. So the agenda for today will begin again with presentation of the evidence from Drs. Grace Lynn and Solomon Lubinga. We will have the CTAF interacting with them, and then we will have an opportunity for public comment and discussion. I believe we have one public commenter signed up for today. And then we'll have an opportunity to talk to a manufacturer representative and to have discussion with the CTAF. We're going to break for a relatively early lunch and come back for further deliberation and votes on comparative clinical effectiveness and value. And then we will have a short break followed by our policy roundtable. And that's where we will have the opportunity again to think about how we can translate our best efforts at understanding the evidence into thoughts on how that can be used by manufacturers, by payers, by clinicians, with patients at the table to create the best approach to bringing these new treatments into clinical care. We'll be done by 3 o'clock, and I'm looking forward to the discussion. So with that, here's our slide we had to introduce you to, and Dr. Heidenreich already did this, to Dr. Hagarde and to Stephanie Smith. So here's their information about potential conflicts of interest. And now, I'm happy to present Dr. Grace Lynn, who will lead us through a summary of the evidence on comparative clinical effectiveness.
Thank you. Good morning. As Dr. Pearson said, I am Grace Lynn. I'm Associate Professor of Medicine at the University of California, San Francisco, and along with my ICER colleagues, we have done an evidence review for drugs for long-term prophylaxis for hereditary angioedema. The key person on the review team from ICER was Felucio Agula, who is the Director for Evidence Synthesis at ICER, and we have no conflicts of interest relevant to this report. So what I'd like to do is give you a brief introduction to hereditary angioedema in the clinical context, and then go through the evidence that we reviewed. So HAE is a rare genetic disease that's characterized by painful and recurrent swelling in various parts of the body. The pathophysiology is that there's a decrease in levels of C1 inhibitor, or in older texts, this may be called C1 esterase inhibitor, which leads to an increase in a substance called bradykinin. And this bradykinin leads to leakage of blood vessels, leakage from blood vessels that leads to tissue swelling. This is an ultra-rare disease. Its estimated prevalence is 1 in 50,000, so that translates into about 6,500 patients in the United States. And attacks are disfiguring, and rarely they can be fatal. This is one of the diseases where actually the Pictures are worth 1,000 words, so I found some photos of angioedema attacks, and you can see that on the left side will be the a normal face, for example, and on the right side will be someone's face when they're having swelling. Attacks can be in the face, they can be in the abdomen. You can have mucosal swelling of the gut so that you have severe abdominal pain and swelling, and you can see that on the slide. Also, you can have swelling of the hands and the feet, which can be very disfiguring and inhibit your ability to do work or go to school. And then finally, attacks can attack your larynx. So you can see this tongue swelling, and this actually is the rare instance where the attack can be fatal because the swelling leads to asphyxiation. This is very rare now that there's treatment available, but it can happen. There are 3 types of HAE. Type 1 is the most common type, and that is due to a deficiency in C1 inhibitor. Type 2 is a bit less common. This is 5 to 6 times less common, and this is due to dysfunction of the C1 inhibitor. So there's adequate levels in the blood, but it doesn't work normally. And then there is a rare type 3, where the prevalence is uncertain, and this is a type where there are normal levels and function of C1 inhibitor. Because there isn't evidence for treatment for type 3, we're not focused on that today. Today we're going to focus on the evidence for type 1 and type 2 HAE. HAE attacks come at a variable rate. They can be triggered by trauma, for example, or they can be spontaneous. They generally last 2 to 5 days if they're not treated. Treatment shortens the course of the attacks. Because this is a very rare disease, there's often a delay of years before a diagnosis is made, resulting in inappropriate treatment. In fact, some patients with recurrent abdominal attacks can even get abdominal surgery because no one can figure out why they're having this recurrent abdominal pain. This unpredictability of attacks results in anxiety and depression around the disease, limitations in the patient's ability to go to work or go to school or participate in leisure activities. And because this is a lifelong disease and the onset is often in childhood, there can be significant caregiver burden as well. In terms of management for HAE, clinical guidelines suggest treatment in 3 situations. So there's the situation of what we call on-demand therapy. So this is when someone's having an attack. There are treatments available to decrease the severity and the duration of attack. There's the situation called short-term prophylaxis. This is where somebody there's a predictable situation where an attack might be triggered. So someone's having surgery, they're having dental work, they know that there's some sort of trauma that might trigger an attack, and you might take medication prior to this activity to prevent an attack. And then there is long-term prophylaxis. So this is routine use of medication to decrease the burden of attacks in patients. The main treatments for all of these classes are C1 inhibitor replacement or drugs targeting the kallikrein pathway. I will note here that the drugs for on-demand therapy and short-term prophylaxis, which we will not spend a lot of time talking about today, are different. Even though they're similar classes, they're different actually from the long-term prophylaxis. Some of the drugs can be used for both short and long-term prophylaxis, but in general, we sort of classify those in 2 different buckets. So for long-term prophylaxis, which is what we'll focus on today, the goal is to prevent or reduce the frequency and severity of HAE attacks. Now, the indications to start long-term prophylaxis are very individualized. There are many factors that go into deciding whether someone should start long-term prophylaxis, and that includes the frequency and severity of attacks. You can imagine that if someone has 1 attack per year, maybe they don't want to take a medicine every day or on a routine basis to prevent that. But if they're having 2 attacks per week, it might be something more reasonable. The impact on quality of life, so how is this disease affecting their quality of life? Access to on-demand therapy and medical care, and then patient preference. Now, just to step back a little and tell you a little bit about the scope of this review before we get into the evidence. So again, we're focusing on the long-term prophylactic treatment for HAE types 1 and 2. And the drugs that we are reviewing are C1 inhibitors, of which there are 2. One called Synrise and one called Hagarde, and lanadelumab, which is the most recently approved drug. And we are looking at a population of patients with HAE 1 and 2, and we're comparing these drugs to no long-term prophylaxis and treatment with on-demand therapy only. So before the advent of long-term prophylaxis, what people did when they had an attack was that they took on-demand therapy to try to attenuate that attack, and that's our comparator in this review. Our key outcome is a reduction in attacks. And our secondary outcomes, you can see here, include things like severity of attacks, quality of life, patient-reported outcomes. So these are the things that we looked for when we went through the evidence base. The drugs that we reviewed, there are 3 of them. As I mentioned, there are 2 C1 inhibitors, Synrise and Hagarde. And you can see Synrise was the earliest drug that was approved back in 2008, and that both those drugs replace levels of C1 inhibitor in the blood. Synrise is an intravenous infusion approved for patients 6 and older, and Hagarde is a subcutaneous injection 3 to 4 times weekly approved in patients 12 and older. The new kid on the block is lanadelumab. That was just approved in August. That's a subcutaneous injection every 2 to 4 weeks and approved for patients 12 and older. In the context of our report, we also talked a lot to patients, including Ms. Smith, about how HAE affected their lives. And we heard from them that HAE attacks can be debilitating and even life-threatening in the case of laryngeal attacks. They cause missed days of school or work. And because the attacks are unpredictable, they cause a lot of anxiety, they can cause depression, and they cause alteration of activities due to the fear of attacks. They can also cause caregiver burden. Some other concerns that came up, since HAE is a genetic disease, it is passed down can be passed down to children. And so there's concern about passing that condition on to children. And then because these drugs are expensive, there's worry about access to medication and out-of-pocket costs. We also heard that, not surprisingly, that subcutaneous therapy is preferred over intravenous therapy for convenience and to avoid some of the long-term side effects from repeated intravenous therapy that I'll get to in later slides. So to get to the evidence for these medications. So there were 3 key clinical trials that were pivotal trials that we found, one for each medication, and that make up the basis of our review. You can see here these are the key criteria in terms of the trial themselves. So the eligibility criteria, you can see there's some differences in eligibility criteria in terms of age and number of attacks. There's some difference in outcomes. So one trial used patient-reported attacks. The other trials had investigator-confirmed attacks as their outcome. And then the baseline attack in the study population was also slightly different. So the Synrise trial did not report this, but the Hagarde and lanadelumab, the baseline attack rate was between 3.3 to 3.5 attacks per month. And then the treatment duration for each of these trials was different, between 12 and 26 weeks. And due to these differences in the inclusion criteria of the trials and the trial design, we actually did not try to do a network meta-analysis where we compared the trials that compared the data head-to-head, the drugs head-to-head. So we actually just reviewed each of the trials separately and the evidence for each of the drugs separately. I'm going to go through the key findings from each trial and just summarize for you. So for Synrise, which is an intravenously delivered C1 inhibitor, this was a phase 3 crossover randomized trial of 1,000 units of Synrise every 3 to 4 days versus placebo. It resulted in a 50.5 reduction in HAE attacks per month versus placebo, and 18% of the patients became attack-free, meaning they didn't have any attacks during the trial. The Synrise also the patients participating in the trial had a significant decrease in the severity of attacks, duration of attacks, and the need for the rescue therapy or the on-demand drugs. There was also a randomized trial in a pediatric population for ages 6 to 12 that also showed efficacy. And since Synrise has been on the market since 2008, there's actually an open label extension trial that has been published that showed also continued efficacy, long-term efficacy of Synrise. So the Hagarde, the subcutaneous version of C1 inhibitor, was also tested versus placebo. And again, this was a phase 3 trial that we reviewed of Hagarde, 40 units per kilogram or 60 units per kilogram every 3 to 4 days. Now, I'm going to review just the evidence for the 60 units per kilogram dose because that's the dose on the labeling and the dose that was more effective. So although both doses were effective, the 60 units per kilogram dose had demonstrated an 84% decrease in attacks over placebo, and 40% of those patients became attack-free. Again, Hagarde also decreased the main severity of attack, the number of days of attack, and the number of times patients needed rescue therapy. For lanadelumab, again, we had one phase 3 trial that compared several doses of lanadelumab and several dosing frequencies compared with placebo. All the doses and dosing frequencies decreased the number of HAE attacks, although the 300 milligram every 2-week dosage was most effective, and you can see there was an 87% decrease in attacks using that dosage, and 44% of patients became attack-free on that dosage. There were similar degrees of decreases in both the attacks requiring on-demand therapy and the number of moderate and severe attacks versus placebo, and again, the 300 milligram every 2-week dosage was the most effective. The package label states then that to start with a 300 milligram dose every 2 weeks, and then if a patient is attack-free for 6 months, there can be consideration for going to a 300 milligram subcutaneously every 4-week dosage. So on this slide, I've summarized for you the clinical efficacy for each of the drugs and the relevant dosages, and you can see that they are effective. I want you to notice here that the rate of attacks in the placebo group is different between the trials. It was less in the lanadelumab trial than it was in the Hagarde and Synrise trials. But otherwise, all the drugs were effective in reducing attacks, and some proportion of patients in those trials became attack-free on prophylaxis. Patient-reported outcomes in those trials. These were few and far between. Each of the trials had some patient-reported outcome, and in general, the patient-reported outcomes showed improvement. So in the Synrise trial, this was an improvement in the SF-36, which is a standardized quality of life metric. In Hagarde, they used a work productivity and activity questionnaire and other quality of life questionnaires that showed some improvement. And then in lanadelumab, they used an angioedema-specific quality of life scale and showed some improvement in using it in the patients who are on lanadelumab. In terms of harms from the trials, there were no serious adverse events recorded in any trial, but again, these trials were of short duration. There were no differences from placebo in discontinuation due to adverse events in a trial. The adverse events that were reported were mild to moderate, the most severe being thromboembolic events with Synrise, although it was not clear whether these were directly related to Synrise or coincidental. The most common adverse event was injection site reaction with the subcutaneous drugs. There is a theoretical risk of virus transmission since Synrise and Hagarde are human plasma-derived products, but that wasn't seen in the trials. That's primarily theoretical at this point. Other benefits and contextual considerations, as I mentioned, 2 of the drugs, Hagarde and lanadelumab, are administered subcutaneously. This reduces the complexity and burden of administration and reduces the risk of long-term complications of repeated intravenous infusions. With repeated IV infusions, you can get scarring of your veins, which can make it difficult to continue to have IV infusions. And lanadelumab offers a novel mechanism of action for patients who are not optimally controlled on C1 inhibitor therapy. It is a monoclonal antibody that targets the kallikrein system. So rather than replace C1 inhibitor levels, as Hagarde and Synrise do, it actually inhibits the formation of bradykinin and thus decreases your risk of attack. Some controversies and uncertainties. The evidence base is limited to small randomized controlled trials versus placebo. We found no head-to-head trials in this area. There is a lack of data on durability of treatment response and long-term safety due to the short duration of trials. The only exception here is Synrise, which has been used for a longer period of time, but both Hagarde and lanadelumab are fairly recent additions. There's very limited data in children, pregnant and lactating women. There's limited data on quality of life and other patient-related outcomes. We did not find much in our review. And there are no clear guidelines on when to start long-term prophylaxis. As I mentioned earlier, this is an individualized decision. So there isn't any particular number of attacks or severity of attacks that would prompt definite start of long-term prophylaxis. We received public comments on earlier drafts of our report. One thing we should note is that in earlier draft of a report, there was another C1 inhibitor drug called Ruconest, and this they had applied for FDA approval for long-term prophylaxis. This is a drug that was already being used for on-demand therapy, and they wanted to expand that indication. It's no longer under consideration by the FDA for long-term prophylaxis, so we removed it from the clinical effectiveness review. It's also removed from the cost effectiveness and budget impact analysis as a long-term prophylactic therapy. It is in there as on-demand therapy because it is still used as on-demand therapy. So to sort of finish up and to summarize, our evidence ratings for the drugs for long-term prophylaxis for HAE 1 and 2, we felt like there was a high certainty of net benefit for C1 inhibitors versus prophylaxis for long-term prophylaxis of HAE 1 and 2, and gave it an A evidence rating, meaning that because there was, we felt like the net benefits outweighed any harms. And this was primarily driven by the fact that we felt confident that there was long-term safety data available for Synrise and from the use of C1 inhibitors as on-demand therapy. For lanadelumab, we rated this as a promising but inconclusive benefit, primarily due to long-term safety concerns. So because lanadelumab is a monoclonal antibody and there have been post-marketing safety concerns that have popped up, without long-term safety data, we did not feel comfortable giving it a rating beyond promising but inconclusive. And then there's insufficient evidence for the three drugs compared to each other. As I mentioned, there are no head-to-head trials, and because of the differences in trial characteristics, we did not do any kind of head-to-head comparison for the three medications. Thank you very much, and I'm happy to take any questions.
Why don't we have people put up, since there's a fair number of interest, have people put up. We'll start with Joy, and then Rita, and then Lisa.
So thank you. That's a very thorough review, and I also read the report. And I did have a question about the data for, actually I have a couple questions, but first of all, the lanadelumab study. Am I correct in my reading that what you had to use for the data were 4 abstracts from meeting reports and no actual manuscript about the efficacy?
That's correct. The manuscript for lanadelumab has not, for that phase 3 trial, has not yet been published.
Okay, and you weren't provided with any kind of pre-publication information from the manuscript? Okay, thanks.
Rita?
Thanks, that was an excellent evidence review. I just wanted to go a little deeper into, if you could give us some feeling, because it seems to me that trials are comparing taking these drugs on demand versus long-term. And so the risks and benefits would depend on how effective are they in those two different roles, like how quickly not really clear on how quickly they work on the on-demand versus sort of the discomfort and inconvenience of having to take something every week. And I'm sure some of it depends on the baseline and the severity of attack. So I'm just wondering, I'll stop after this because there's a lot of questions in there, but a range, is there usually a range in severity of attacks? Does it vary by person to person? And then I do have another question after this.
Yes, those are excellent questions. So yes, there is a range of severity in attacks, ranging from mild to severe. And patients, and we actually have patient experts, so Stephanie, please chime in if you have additional context that you can give us. Patients choose to treat their attacks based on, whether or not so all moderate to severe attacks are recommended for on-demand treatment, but for mild attacks, some patients may or may not choose to treat those attacks. The on-demand therapies, there are several. Some are intravenous and some are subcutaneously delivered. The evidence for the on-demand therapy is that they do shorten the duration of the attack and the severity of attack, and the earlier they are used, the shorter and less severe the attacks are. And I think, you'd have to ask patients in terms of how they judge when to do on-demand therapy versus, not treat an attack. And then again, the guidelines there isn't a lot of experience in this area with long-term prophylaxis, so it's really less clear, and it's really an individualized decision about when your quality of life might be affected to the point where you would want to take routine medication every 3 to 4 days, rather than treat your attacks on demand. The variability in attacks, in the rate of attacks, ranges from very rare attacks to once every 2 or 3 days. I think we looked at studies from the United States and from Europe, and had a range of attacks. We had a mean attacks from about 0 to 4 per month. So, some people had very rare attacks. Some people had attacks up to once or twice a week. And I think that's sort of the sort of normal range. The attacks also, the attacks can be in any of the body parts. So most patients have attacks in several places. And so, for example, somebody with who has tongue swelling and a laryngeal attack, that might be something that you are more likely to treat because of the risk of mortality than maybe some swelling in the hand, for example, that maybe is less less impactful on your quality of life for a mild attack, for example. Maybe I'll actually, Stephanie, if you have any insight into that'd be helpful.
Yeah. For me and my family, all attacks are severe. You can have it in your hand, and then it can travel, like she said, to other body parts. I would rather be safe and treat my sons. They do the on-demand therapy. I would rather treat them before it gets worse. Like she said, the sooner the better. My younger son, Landon, has gone to bed before with an upset stomach and not told anyone. And then I heard him a couple hours after he had gone to bed, and he was in his bed thrashing around, and I went and woke him up, and I said, "Landon, what's wrong?" He said, "I'm having an attack." And I'm like, all right, let's go to the bathroom, because I knew he was gonna get sick. So he went in and got sick, and he was in so much pain, he actually passed out on the commode. And I'm yelling for my husband to start mixing the medicine because we needed to get it to him right away. And he's like, "When can I take medicine to prevent this?" And he's under 12. And I'm like, well, we're gonna have to talk to our doctor about that. We have an appointment coming up, but the sooner the better, because it does come on very quickly for him. My older son is less frequent to attack, but he has gone to school and been like, "Oh, I got an upset stomach, I'm just gonna not deal with it." And then he's come home and he's like, "Mom, I'm in an attack," like full blown. I'm like, "Why didn't you tell us?" He's like, "I didn't want to miss class." And I'm like, "You could miss school the next day because we didn't treat right away." So I'm trying to get them to understand that the sooner the better for them. Just so they're not in pain and they're not missing daily things that, normal kids can do. So for them, it's better to treat right away. And then I'm on Hagarde So I infuse or inject 2 times a week to prevent the swelling. Prior to Hagarde, I was attacking once a week. So it's been a good change for me from going from 1 time a week sticking a vein because I was using the IV therapy to twice a week sub-Q injection. So it's really improved my quality of life.
Thank you, that's very helpful. This is a shorter question, but were in either of the trials, or any of the trials, were there any measures of the effectiveness of the blinding? Because sometimes patients know if they're getting active drug or placebo.
Yes, that wasn't stated in the manuscripts or the abstracts that we read, so I don't know that answer that.
Lisa's?
Yeah, thanks again for the nice review. Looking at Synrise, you mentioned there was the long-term open-label data on safety. Could you remind us how long that was, and were the thromboembolic events seen during that follow-on time as well?
So, excuse me. So the open-label Synrise trial, the open-label extension, I believe, and Felicia, correct me, this went on for a year? About 2 years. About 2 years, thank you. And there were, in the thromboembolic events, were, I believe, not seen in that context. We didn't find any. Yes.
Okay, Kim?
I actually was going to address that too, so. Do you know anything about the 2 deaths that were assumed to not be related to the drugs?
No, there was no data provided on that, no details.
I think we'll go Alex, then Rena, and Jeffrey.
Thank you for a terrific summary. I'm just trying to get a sense of who the population we're talking about is. We're talking about people who are eligible for prophylactic therapy, and that seemed to differ between these trials. And so when we're saying that the ICER rating, for example, is A for the C1H inhibitors, who are we talking about, and how many attacks per month are we talking about? And then how big a population is this? I know it's ultra rare, but how rare are we talking about?
So those are excellent questions. So to address the first question, so the trial inclusion criteria for the C1 inhibitors was 2 attacks per week. And let me actually go back to that slide. So there we go. So per month, excuse me, per month, 2 attacks per month. And this is, again, because this is an ultra-rare disease, these are small trials. And you can see that the baseline attack rate per month was actually a bit higher, actually in the Hagarde group of 3.3 attacks per month. So this is a population where, since we don't have really good guidelines on when to start prophylaxis, it's sort of a clinical, I think that what the inclusion criteria reflects sort of the clinical minimum of what people thought would be number of attacks per month that would qualify someone that they'd want to take medication on a routine basis rather than just doing the on-demand therapy. So it's again, I think because this is, there are 6,500 people in the United States with these approximately. So all of these trials are very small. So, you can see that there's wide variation also in the attack rates. So I don't know that there is any clinical, sort of, agreement on when somebody should start long-term prophylaxis, and therefore I think the drug manufacturers sort of set a sort of an artificial bar of this is when we think that people might want to start long-term therapy. Does that answer your question? I know since there aren't a lot of data in this area and there aren't a lot of patients, it's sort of hard to say, well, yes, these are exactly the people who should be in the trial, and how does this reflect the broader community? I think we just don't know. I think the answer is we just don't know.
Marina?
I am interested in the group that becomes attack-free. In all three trials, there was a percent. The Synrise had 18%, and the other two were 40 or 44%. Were there any baseline differences in the patients who became attack-free, or factors that seemed to be predictive of who became attack-free? And then my other question was about how long a follow-up. You said in the Synrise trial, there's a long-term extension trial going on. So is the 18% coming in long-term follow-up from Synrise and shorter term in the other two?
Sure. Those are good questions. So in terms of the first question, we did not have data on which particular patients became attack-free. So that was not broken down for us by the manufacturers. So we don't have any data on any predictive factors. For the second question, the 18% actually comes from the trial, not from the open label extension. And I don't recall in the open label extension if they actually reported the number of patients who were attack-free, who remained attack-free. I don't think that was in the open label extension.
I mean, that would be very important. Oh, and actually one more question on this. So in the lanadelumab, they reduced the dose if you were attack-free for 6 months. And in the others, was there any attempt at dose reduction?
So these were actually dose-ranging trials. So in the Hagarde trial, people were either on 40 or 60 for the duration of the trial. In the lanadelumab trial, they actually didn't do the reduction. That each group was either on the 300 milligrams every 2 weeks or the 300 milligrams every 4 weeks. So there was no crossover and there was no mixing of that. That is a suggestion based on the data.
And I think our final question then will be from Jeffrey. Oh, Joey will have one too. Okay.
So thank you very much for that presentation. I was wondering if you could offer us any intuition about the finding, looking at Hagarde in particular on this slide. It looks like you can see a reduction in attacks per month from maybe like 1 every week to 1 every 2 months. It looks as well like you've got a 40% proportion of patients that go attack-free. And yet on the next slide, slide 27, it says that when you looked at quality of life, using the EQ5D, which will come up in the modeling, they don't find a difference. So I wondered if you had any intuition for us about that.
Yeah, that's a good question. The quality of life measures weren't very well described and when they collected them in the trials. So I don't know at what point they collected them. So one possibility could be that they collected them, that they collected them only during the duration of the trial. The other thing is I think the differences, those were reported as means. And so that is a mean of all the patients in the trial. So 40% became attack-free, but there were also patients in the trial who did not become attack-free, and that may account for, may balance out the difference. Because there weren't detailed data, that's the only speculation. But I do think that the other thing is these were trials of short duration, so you may not have seen significant improvements in quality of life because of the short duration of trials.
Okay, Joy?
I have 2 questions, but they're quick. On the Synrise long-term open label follow-up, did they report any adverse effects from the repeated IV administration? You said there were no thromboembolic events, but how about, did they talk about venous scarring or anything like that?
They did not report that I can recall. Yeah.
And then my second question is just about the prevalence of people that would meet criteria to be in these trials, like of everybody with HAE. Do you have any sense of that, maybe from how many had to be screened in order to get the recruited population, or any other studies that you've seen about, like, the distribution of the severity?
So there are some survey studies, and again, these are survey studies, so I don't know how good the data are in the United States. That there are So these are basically have to do with severity and impact on quality of life. So people will report that there's probably 10% or so of patients who have attacks. And I'm sorry, I'm remembering this off the top of my head, so I may misquote some of this, but who have attacks pretty rarely. The majority of people have attacks, between once a month and once a week, and then a very small minority have attacks more than once a week. In terms of screening for trials, all of these trials were multi-center and mostly at large HAE centers because of the rarity of the disease. And so I think, perhaps Marco actually has some insight into this because he was involved in many of the trials. So I think these were mostly patients who were known to have HAE and were being seen and treated at these HAE centers. So, in terms of the screening of patients, I think that this was a known population of people already diagnosed.
Right, what I meant is screening, like to have enough episodes to qualify.
I don't know the answer to that.
Okay.
Yeah.
I just wanted to add a quick note on the long-term data.
I can talk loud.
All right. So long-term data for Synrise, there were 5 thromboembolic events out of the 146 patients, but they all had underlying risk factor for thrombotic events, and the investigators said it was not related to the use of Synrise.
Thank you for the clarification, Lucia.
I'll go with Pat and then Annette.
I have a question for Stephanie, actually, because I didn't see you on the agenda to make remarks, so thank you for coming. Can you tell us about the age of onset where you experienced attacks and for your family members? And without, if only you had access to Ondemand, is there an increase in severity or number of attacks over your lifespan, or is it pretty consistent? Because from the report, there's no information on that.
Yeah. I had my first attack when I was 13. When I was 13, I started my menstrual period, which can cause attacks. Going through middle school and high school, I had very infrequent attacks, but when I got into my 20s, I started attacking like once a week. And prior to starting Berinert, which I started in 2010, I was not doing anything. I was sick for 3 to 5 days, missing school, missing work, missing parties, Christmas parties, going out with friends. And with my 2 sons, Wyatt had his first attack at the age of 6. We were actually on his kindergarten field trip. Thankfully, I was with him and was able to recognize that he was having an attack. And with Landon, he was 7 when he had his first attack. And with them being so young, having attacks, I am worried about doing IV therapy on them and causing scar tissue on their veins. I try not to use the same vein for them. Like, I know where I infused last, so we try to alternate sites just so we don't cause scar tissue on them. I can tell on myself that I do have scar tissue on some of my veins from the use of IVs weekly. So going to sub-Q has helped with that. But I started Hagarde in 2014 in the trial, and when I started the trial, I did not know if I was on the placebo or on the medicine, and I continued to attack. And then at the halfway point, we switched, and then I was attack-free for about 17 weeks, which is the longest I had ever gone without an attack prior to me officially attacking at the age of 13. And I have not had an attack since the trial. And then I started Hagarde after the trial was over. So I've been attack-free since 2014.
That's great. So it seems like there's not a pathway over the lifespan where you would grow out of these or decrease after menopause? Okay.
No, I have family, I come from a very large family. History of hereditary angioedema. My mother is one of 9. 7 of her brothers and sisters have HAE, and my grandmother was one of 13, and 11 of her brothers and sisters had HAE. And I did not know my grandmother's family, but my grandma still attacked when she was elderly, and I have aunts and uncles that are continuing to attack in their 60s.
Thank you. It's been a great discussion. I think in the interest of time, we want to go on to our next presentation. We will have some opportunity for questions before lunch, and we'd like to get our Dr. Hagarde as well involved. But at this point, I'd like to bring up Solomon Lubinga to go over the cost effectiveness data.
Okay, thank you very much. I'm Solomon Lubinga. I'm a senior fellow at the University of Washington in the Department of Pharmacy. And I'd like to walk you through our approach to the cost effectiveness. I'd like to walk you through our approach to the cost effectiveness analysis and the main results. So this section really was a joint effort between myself, Dr. Josh Carlson at the University of Washington, and Dr. Rick Chapman at ICER. And we have no conflicts of interest relevant to this report. So our objective for this was to estimate the cost effectiveness of long-term prophylaxis with these drugs against acute attacks in patients with HAE. So I'll now walk you through our inputs and assumptions. So what we did was to construct a Markov model in which we follow patients in monthly cycles over a lifetime. We've talked a little bit about this, but the age and sex distribution, we chose age and sex distribution as a weighted average across the 3 major trials. The mean number of attacks per month, again, was chosen to reflect. It was chosen to reflect the average monthly attack rate in the prophylaxis population. And what we did was we estimated this as from the major trials, the two trials that reported average monthly attack rates. So we did apply sex-specific weight distributions that we derived from a U.S. adult population. Our interventions again were Synrise, Hagarde, and lanadelumab, and we compared these in a pairwise fashion to no long-term prophylaxis. Our key outcomes were QALYs gained, incremental cost per QALY gained, and incremental cost per attack avoided. And our best case analysis took the perspective of the U.S. healthcare system, so we focused on direct healthcare costs, and we did do a scenario analysis in which we accounted for indirect costs. So that's a societal perspective, and we report all our costs in 2018 US dollars. So this is sort of a pictorial representation of our two-state Markov model in which patients are either alive with HAE or dead. And what we did is we accounted for background mortality using US life tables, and we also accounted for HAE-specific mortality. So in the alive with HAE state, so in the alive with HAE state, patients experience acute attacks. So what we do is we track the number of attacks, the attack-free duration, the prophylaxis drug costs, on-demand drug costs, other healthcare costs associated with acute attacks, as well as indirect costs. So for each attack, what we used this decision tree-like structure to track severity, so mild, moderate, and severe. We also tracked whether attacks were treated or not, the setting of treatment, whether there was a follow-on ED visit and a follow-on hospitalization. For severe attacks, we split this between those which are non-laryngeal and those which are laryngeal. So for severe, so we assumed that mortality would only occur from severe laryngeal attacks. Now for non-fatal laryngeal attacks and severe non-laryngeal attacks, we similarly track the setting of administration, whether there is an ED visit, whether there is a follow-on ED visit, and whether there is a hospitalization. So using this decision tree-like structure, for each attack, we calculate the mean costs, the mean direct costs, mean indirect costs, disutility, the probability of death, as well as the duration of acute symptoms. So this table represents, we're just summarizing the severity distribution, the proportion of attacks the proportion of severe attacks that are laryngeal, and what you can see from here is also that the fatality rate from laryngeal attacks is pretty low. Also, I'd like to say that we also estimate that approximately 2% of attacks in general are laryngeal. So that's about 11.5% of the 17.2%. Couple of assumptions. So most mild attacks are treated, that's approximately 90%, and all moderate and severe attacks are treated. Attacks last a relatively short duration, so 1 to 2 days depending on severity, and untreated attacks last an extra day. So fatal laryngeal attacks we assumed would go really quickly, about 4.5 hours. Most mild and moderate attacks are treated they are treated in a home setting, either by the patient themselves or by a home nurse. And we assume that all severe attacks are treated in the ED, and about 41% result in a further hospitalization. So our treatment effects, we accounted for two types of treatment effects. So an effect on the number of attacks, as well as an effect on the severity of attacks. So in terms of severity of attacks, only Hagarde had data on severity of attacks. So we did account for that in our base case. But we also sort of performed a scenario analysis in which we assumed that all the other drugs had a similar effect on severity of attacks as Hagarde. So utilities, we've had a sort of a discussion about the proportion of patients who are attack-free. So our approach to utilities, we try to account for this. So for patients who are attack-free, what we did was to apply a baseline utility and then a utility decrement per decade increase in age. Then that's for patients who are attack-free. Now, for patients who are experiencing attacks, that proportion of patients who are experiencing attacks, what we did was during the attack-free periods, we applied the same baseline utility, the disutility, a utility decrement associated with a 10-year decade increase in age, and then a utility decrement associated with, so a utility decrement per attack. Then again, for that proportion of patients who experience attacks, during when they're experiencing attacks, we also we applied the utility decrement. That's a function of the severity of attacks. And this data come from a cross-sectional EQ5D survey of Swedish HAE patients. So this table here just represents it represents the dosing schedules and unit costs that we use to calculate the long-term prophylaxis drug costs, and we assume that prophylactic therapies are taken on a lifelong basis. This table here shows the on-demand drugs, the dosing schedules, and the costs that we use to calculate the costs of treatment of acute attacks. So we just calculated the average cost per attack, assuming that utilization of these drugs was evenly distributed across treatment settings. And we also accounted for other direct healthcare costs by treatment setting. On to the results. So we estimated monthly prophylaxis drug costs, and these ranged from approximately $31,000 for Hagarde to $50,000 for Synrise if it's administered by the physician. So this table represents our main results, the discounted lifetime results for our base case analysis. So what we observe is that in general, so across all three prophylactic therapies, the lifetime costs for these drugs are pretty high, ranging from about $9 million for Hagarde to about $10 million for lanadelumab. What you'll also notice from this table is that the lifetime costs for acute treatment if patients do not receive long-term prophylaxis is also pretty high, approximately $10.1 million over a patient's lifetime. So what prophylaxis does is that it reduces the lifetime acute treatment costs, sort of ranging from about, that would range from about 1.3 to about 5 million. And this is a direct result of a reduction in the number of acute attacks experienced over a patient's lifetime. The other thing you'll notice from this table is there's practically no effect of, we did not observe a really significant effect of these drugs on overall life years, but we did observe an effect on quality-adjusted life years. Again, the effect on quality-adjusted life years is related to, it's related to both a reduction in the number of acute attacks and also for Hagarde, a shift in severity. So there are fewer severe, patients experience fewer severe attacks. So the ICERs compared to no prophylaxis, as you can see, most of these drugs, all of these drugs have ICERs that exceed the 150,000 per quality threshold. One-way sensitivity analysis. So this tornado diagram illustrates what we saw, what we found were the key modal drivers. The baseline attack rate was had the highest impact on the overall ICER, the prophylaxis drug costs, as well as treatment effects on attack rate and the proportion of mild attacks that are treated. And these key modal drivers are pretty much the same across, they're pretty much, these key modal drivers are pretty much the same across all the prophylactic therapies. What we wanted to draw your attention to was, so we'll discuss a little bit more about the baseline attack rate, but as you can see, just very small relative changes in drug costs produce very large changes in the incremental cost effectiveness ratio. So we varied drug costs by plus or minus 10%, and you can see when we reduce the costs by, for example, when we reduce the cost of Hagarde by 10%, it pretty much becomes dominant over no prophylaxis. And when we increase it by just 10%, the ICER exceeds $800,000 per quality. So these are the results of the probabilistic sensitivity analysis. Just quick summary, so over 5,000 simulations at cost per at 150,000 cost per quali. All the prophylactic therapies had a less than 50% chance of being cost effective. So only Hagarde approaches the 50% chance of being cost effective. And Synrise, at all these thresholds, Synrise does not appear to be cost effective at any threshold. When we varied the baseline attack rate, so what this graph shows is that when the baseline attack rate increases, the incremental cost effectiveness ratios generally improve. And we calculated that the threshold attack rates required to achieve a 150,000 per quali threshold were about 5.9 for Synrise, 3.4 for Hagarde, and 3.8 for lanadelumab. So we conducted a number of scenario analyses. From a modified societal perspective, only Hagarde only Hagarde had an incremental cost effectiveness ratio that dropped below the 150,000 per quali threshold. And we've discussed a little bit about the lanadelumab dosing. So what we found was that lanadelumab would become dominant over no prophylaxis if all patients who are attack-free on every 2-week dosing switched to every 4-week dosing at 6 months. And when we try to estimate a threshold proportion of patients that would successfully switch, what we found was that approximately 80% of attack-free patients would need to be successfully switched to the 4-weekly regimen for lanadelumab to be dominant over no prophylaxis. And approximately 68% would need to be switched to achieve a 150,000 per quali threshold. A couple of limitations, and we've touched on these as part of the discussion of the clinical section. So first of all, I'd like to point out that there is no natural history data on the attack rates over patients' lifetimes. Yet our model actually assumed a constant monthly attack rate over patients' lifetimes. We also assumed that a constant treatment effect over patients' lifetimes. Yet, as we've observed, the sample sizes in the clinical trials were pretty small, and the trials were of very short duration. Our best case analysis only captured Hagarde's treatment effect on severity distribution. The other limitation is that we had no good data on utilities and HAE-specific mortality for US patients. So what we did is we borrowed data from European HAE patients. We did have interest in exploring a less frequent lanadelumab dosing, as stated in their FDA label, but were limited by lack of long-term efficacy and real-world utilization data of a lower lanadelumab dose. So we just did this as a scenario analysis. We did receive a number of comments that we tried to respond to. We updated our initial model based on these comments. So first, we did update the proportions requiring additional doses of on-demand treatment, and it turns out that these proportions that require the proportions requiring additional doses of on-demand treatment, turns out that is a very important variable in determining the cost effectiveness of all these drugs. We also added a scenario analysis to evaluate the impact of every 4-week lanadelumab dosing in patients who are attack-free on every 2-week dosing. We also applied gender-specific weight-based dosing for Hagarde and all on-demand drugs that are dosed according to weight. So in summary, all the prophylactic therapies we assessed were exceeded the 150,000 per quality cost-effectiveness threshold. Hagarde dropped below this threshold when it was evaluated from a modified societal perspective. Lanadelumab did become dominant over no prophylaxis when approximately 80% of patients who are attack-free on the 2-weekly dosing successfully switched to a 4-weekly dosing regimen at 6 months. And lastly, which we found very key in this model, is that results were extremely sensitive to assumptions around the baseline attack rates, prophylactic and on-demand drug costs, as well as the treatment effect estimates that we used. And with that, I'd like to invite some questions.
Yeah, I think we have time for a couple questions before lunch. I know there's a request, at least one of the questions is for our clinical expert, so I'm not sure if he is still with us. Maybe we'll just go with him. Dr. Hagarde, are you on the phone?
He's on a delay, and Matt,
I don't believe he can hear us.
Okay, so let's go with a couple questions. We may need to limit it, try to make them brief.
I do have 2 questions, but I'll make
Sure.
them brief. So one is on slide 55. I wanted to understand what the data was that you changed the assumptions about the on-demand treatment. On what evidence?
Yes, I'm here. Can you hear me?
Yes, we can hear you. I think, well, we do have a question for you, and I think Annette's going to, you want to ask your question?
Yeah, I wanted to ask, how quickly do the acute attack therapies take effect in the patients? And when they talk about treating earlier, how late into an attack can they treat without having to go to the emergency room? And are we talking about all IV therapies, or are some of these also subcutaneous acute attack treatments?
Almost certainly he's on delay, and we'll need to wait for him to hear that.
I think I have a delay in receiving the questions. I don't know if it is appropriate for me to answer now.
Yes.
But what I can say is that in order to have the resolution of the attacks, it usually takes about 8 hours, which can be reduced to a shorter time if you treat early. The use, yes, because I have to use the web seminar because the other, can you maybe,
We got part of that.
All right, well, hopefully we'll get back to him. Maybe, Rita, we can finish your question.
Can I ask my question?
Okay.
Yeah, so the question was, on what data did we base the change in, what data did we base on to change the proportions requiring additional doses of on-demand treatment? Yeah, so this was, we had a lot of back and forth with this, but we ended up choosing, we tried to choose publicly available the best publicly available data we had. So I believe for Berinat and Firazyr, we used an observational study, and then let me just switch back a little bit. So for Berinat and Firazyr, we used an observational study that essentially showed about 2% and 13% respectively would require additional doses. Then for Calbitor, we used a study that pulled together a number of studies of acute treatment of HAE that where patients were allowed to receive additional doses of Calbitor. And what that study showed was approximately 12% of patients required an additional dose of Calbitor. Then Ruconest, we've had a bit of back and forth with this, but we used data from a phase 2 open. So we used data on from an open label extension study of the phase 2 trial of Ruconest that essentially showed that approximately 10.1% of patients required an additional dose of Ruconest. So these variables are pretty much very important in determining the actual cost of, the average cost of on-demand treatment of acute HAE attacks. Yeah.
Yeah, Alex, and then Jeff, if you could,
All right, very
and then
quickly.
we'll probably have to go to public comment.
Could you comment on the difference between the base case and the modified scenario? I understand the modified scenario, the societal perspective includes indirect costs.
Yeah.
What were those indirect costs?
So first, I think ICER's guidance basically says if indirect costs are low, we do not include those indirect costs within the base case. Have I got it right?
Sure. I'm not sure if I'm checking the microphone. Test. That's on. Is that on now? Hello? Oh, good. So for an ultra-rare disease, ICER's guidance is that we should have dual base cases of a modified societal perspective and a health system perspective if the societal, if the healthcare system costs are not very large relative to the societal costs. This turns out to be a case where because the healthcare system costs are so large relative to the societal costs that it didn't end up as a dual base case, it ended up as a separate scenario analysis, which is what we would typically do for something that isn't an ultra-rare condition. So we ended up doing it as a scenario analysis, which is just what you would have seen for any non-ultra-rare condition that ICER was doing, where it wouldn't be a dual base case, but would be separate. In terms of what those costs were, I'll turn that back over.
Yeah, so in terms of what constitutes those indirect costs, as Stephanie has said, just having, during periods of acute attacks, patients are unable to contribute productively to economic activity. So I think there was a 2010 study that tried to look at these productivity loss costs in HAE patients in the United States, and they split them by patients who have severe attack, mild, moderate, and severe attacks. So those are the estimates we used for indirect costs.
All right, one more question from Jeff.
Yeah, since they were very sensitive to the costs in all these, can you give us a sense of the rate of increase in the rescue medications? Because we know those sometimes can go up dramatically and could potentially have a long-term benefit for prevention. Are they going up at 15% a year like we sometimes see, or do you have any sense on that?
The rate of increase in costs of rescue medications, I don't really have any data on that. What I'll say is I mean, the rescue, these rescue medications have been around for quite some time. So essentially what we did was to just take the most recent cost estimate for these rescue medications. That's what we used in the model. I think what's more important is the proportion that require